The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Hello and welcome to another edition of Your Health, Your Choice, the program where we help you to make right decisions through the empowerment of knowledge about your health. So today we're focusing on insulin therapy, and once again we have with us Dr. Claude Khan, diabetologist, and we want to just begin by having you explore perhaps what insulin therapy is all about.
So we're coming back to the bread and butter of what I love doing, diabetes. Over the last few months, we've been looking at a variety of other issues from my family medicine background. But I decided as we're coming into August and leading up to World Diabetes Day in November, we'll come back to some of the basics of diabetes. So what we want to do today is look at mainly type 1 diabetes and insulin therapy, but we want to talk generally about different ways of giving insulin. But just to kick off and say, what is diabetes? And we often talk about it on the program. Diabetes is basically due to a high blood sugar. So we no longer test the urine for sugar to diagnose diabetes, because actually, just to divert, there's a new class of drugs in treating diabetes that encourages urinary excretion of sugar. So it's a whole new paradigm shift. So
lots of technological advances.
Absolutely. It's an absolutely exciting time to be involved in diabetes care. After years of having just 2 or 3 drugs to treat diabetes, we now have such a wide range of options. So we're coming back, though, to insulin therapy and looking at why are people diabetic. Now, basically, a lot of patients come in and they are blaming the lifestyle, the lack of bad eating, not enough exercise, and certainly that has a lot to do with diabetes. But when we talk about type 1 diabetes and type 2 diabetes, it's a different ball game. In fact, most diabetologists would say these are 2 different diseases completely. And very often patients ask, am I type 1? Am I type 2? And we often have to go through the process of explaining that. So diabetes is basically a high blood sugar. Now, I do remind patients, Linda, and I know this is a bit controversial, that sugar is not bad.
We need some sugar in our system. Yeah.
So the problem with diabetes is that the sugar is in the wrong place. Sugar is the basic metabolic fuel to get your brain working, your heart working, your muscle working. And what happens with diabetes is that because there's not enough insulin in the system, that the sugar in the blood cannot get into the cells. So I want to repeat that. The problem with diabetes is not just too much sugar, but the sugar in the blood cannot get into the cells because the insulin is either not enough or the insulin is not working on the receptor sites. And we can come back to that in a few minutes.
So essentially what we're saying is that patients obviously need to be diagnosed.
Yes.
And we've been through the ABCs of diabetes. So you get your A1C test, HbA1c test done. The B, your blood pressure is checked, and C, your cholesterol testing. Then you go to your GP or your diabetologist, and then it's diagnosed as to whether you have
type 1 or type 2.
Type 2.
Yes.
Okay.
And I'll come back to how we do that. But let's get into
the type 1.
Type 1, right.
Yes.
So if we can bring up slide 3. What slide 3 shows is, that's slide 3. So previously referred to as juvenile diabetes or insulin-dependent diabetes. But I want to explain in a minute why we have changed that. There's some big words there. It's polygenic, it's multifactorial, and it's autoimmune. And you can't see the 3 circles interlocking circles.
Like a Venn diagram.
Right.
Yeah.
So you have what is called a genetic risk, you have the diabetes happening, and then you have the environmental factors.
So diabetes is merged as a result of both of those things.
Both, right. So genetics and environmental factors.
Yeah.
And the problem is we still don't know what really causes type 1 diabetes. There's a lot of research going into this. What is interesting is in the Scandinavian countries, Sweden, Finland, and Northern America, mainly Canada, type 1 diabetes is more common than in the tropical climates. So still type 2 diabetes is more common, but type 1 diabetes is much more common in those countries as compared to Trinidad or Africa.
Well, we've reached epidemic portions with type 2.
So the thinking is that it might be a viral trigger because of the winter periods where people are indoors. There might be a viral trigger to type 1 diabetes, or it might be stress related. But let me quickly add that while we associate type 1 diabetes with young kids, so, you know, I have some patients who have had type 1 diabetes for 30 years, but they were diagnosed at 11 or 12. The caution I would say to doctors, colleagues out there is don't assume every 40-year-old coming into you is a type 2. Because we have something called LADA.
I don't understand that.
Right. I was waiting for you to ask me that.
Yeah. So what's LADA?
I can impress the people who wait. Look, it's called latent onset autoimmune diabetes. In other words,
latent onset.
Latent means later on in life, where you assume that this is going to be type 2, but in fact, something triggers off the immune system, and we have the autoimmune system attacking the beta cells, and you have type 1 rather than type 2.
Okay. So what do we do next with type 1 diabetes?
So we have a nice clip. I think we can show the clip on type 1 diabetes, and then we can come back and look at what we call the epidemiology, how frequent it is, etc. So let's show the first clip that we have tonight.
You or someone you know may have been diagnosed with type 1 diabetes. This video will help you understand what it is and why it's important to keep it under control. Type 1 diabetes is a condition where your pancreas makes little or no insulin. Insulin is a chemical your body needs to keep your blood sugar at a normal level. Carbohydrates are substances your body uses to make energy. After you eat food that contains carbohydrates, it eventually goes to your small intestine. In your small intestine, the food is broken down into single sugar molecules called glucose. The cells in your small intestine soak up the sugars, which pass into your bloodstream. When the blood reaches your pancreas, it detects the high amount of sugar in your blood. Normally, this causes your pancreas to put a chemical called insulin into your bloodstream. The insulin reduces the amount of sugar in your blood to a healthy level. How does insulin do this? As the blood moves through your body, the insulin and sugar exit the bloodstream into your tissues to reach your cells. Most cells have structures on their surfaces called insulin receptors. When insulin flows by, it attaches to the receptor. The insulin acts like a key in a lock to open up the cell, so the sugar can get inside. Now your cell can use the sugar to make the energy it needs to work properly, and your blood sugar level drops back to its normal range. If you have type 1 diabetes, your pancreas loses its ability to make enough or any insulin. This can result in high blood sugar levels and other complications. In type 1 diabetes, your immune system attacks some cells in your pancreas by mistake. As a result, your pancreas makes little or no insulin. Without insulin, sugar cannot get into your cells. Without sugar, your cells don't have energy. And since the sugar is locked out of your cells, it builds up to a high level in your bloodstream. This is a condition called hyperglycemia, which can lead to serious complications. If you have questions about type 1 diabetes or any medications you have been prescribed, speak with your doctor. It is important to take your medications as directed by your doctor. Tell him or her about any side effects you have.
It's quite a clear explanation of that from the very outset of from when you're eating all through the digestive system and the various parts of the body that are generating that the tract of the glucose.
Right.
Really, really clear and
it's
well explained.
Fantastic clip. Now, so what I would say immediately is that we see how important, well, not just important, but how critical insulin is for life in type 1 diabetes. So what I would really want to encourage patients to understand that in type 1 diabetes, there's no place for tablets. There's no place for herbal remedies. Now, I can deal with some of the herbal remedies in type 2 diabetes, but when you're talking about, and this is where the big misunderstanding, and as I always say, Linda, you try to calm me down at this point, but all the fake doctors out there who do not understand type 1 diabetes, and you're trying to treat patients who are type 1 with herbs and with omega XL and with all the other remedies, you are on dangerous grounds because these patients could go into ketoacidosis.
Can you explain that?
Okay, so when there's not enough insulin, the sugar cannot go into the cells. Therefore, the cells become starved of energy. It's like someone who's running, an athlete. You sometimes see people cramping up after a race because what happens is the muscles are not supplied with enough oxygen and glucose as energy, and they go into an acidotic state. The same thing happens with type 1 diabetes, and that's a life-threatening. I'm not overplaying this.
About all the organs in your body.
All the organs will shut down, and people die of ketoacidosis. So I am begging people to understand in type 1, if you have patients coming into you and you're not sure whether that person's a type 1 or type 2, I would suggest that type 1 diabetics need to be under a specialist. Generally, type 2s can be treated by family physicians as well, but type 1 diabetes need to be treated by a specialist.
And insulin is important.
Well, it's not just important, it's
crucial.
It is indispensable. You cannot treat type 1 diabetes with tablets.
Without insulin, they
will die.
That's clear enough.
Yes. So I have another slide here, slide 5, which just shows the epidemiology, what we call the age group. So the peak age is between 5 to 7 and early puberty. So that's 12, 13. But 30% of cases present between 18 and 40 years. And this is where the confusion arises. Because a lot of people think it's just the youngsters presenting with type 1. And there's a genetic association in regards to the risk of developing diabetes.
So, genetics and that 30% are the ones that we're missing sometimes.
Yes, they're being treated as type 2s. And the sad thing about this, I have patients coming into me, they're trying to starve themselves. They're being told no rice, no roti, no pasta, vegetables, salad, and a little bit of protein all day. Can I say any doctor or nutritionist that is advising you that you cannot have carbs is not giving you the right advice. You need carbohydrates to survive. The key to this, and when we talk about what we call
quantities.
Yes, when we talk about pump therapy, which I will talk about later on, this is an insulin pump. I wasn't going to show it just yet, but this is about to come into the market here in Trinidad. Finally, we're about to get insulin pumps, and I'll talk about it in a few minutes. That you're trained to count carbs.
Yeah.
And then you can dial up the insulin you need, and it's a much more accurate way.
So basically, it's about a balanced diet, making sure that you're not overdoing the carbs, but then you're including your proteins, your vitamins.
Absolutely, a balanced diet. And I really feel sorry for patients sometimes because they've been given this advice. They come in and they're really distraught because they're saying to me, or to other doctors, look, I'm trying my best, I don't know if people on the show can hear that thunder. You just said
it's a rainy season.
It's a rainy season, but they're trying their best. They're trying to eat properly, etc., and they just cannot control their blood sugars. And even with diabetes, people come in with this feeling of failure.
Yeah. Guilt.
Yeah. And they think that they're failed, they go into depression, and we really have to explain to them, listen, it's not that you're doing anything wrong, it's just that your therapy is not right.
Yes. Okay, good. So should we move on to slide 7?
Well, I was going to go, the other slide was a little bit complex, but I wanted to talk just I don't know how long we have before the break. We have to go to a break.
Yeah,
when we come back, we'll just compare type 2 diabetes.
Okay.
And then we'll go on to insulin therapy.
So when we return, we're focusing on the comparison between type 2 and type 1 diabetes. And just don't go away.
Hey, listen, we have some great news for you, our loyal viewers. No, we love to interact with you on a daily basis. So sometimes we do it via telephone, otherwise Facebook. But now we've added our new WhatsApp phone number. That's right. You can now text us live on our various programs right here on ACT and The Voice at 360-0105. That's 360-0105. Send us your comments, send us your questions, and get this even better. After the lights come off, you can continue sending your comments and your questions, and we'll respond to them the following day. So that's right here on ACT and The Voice, we have now opened up more mediums for you to interact with us. Facebook, telephone call, and now you can WhatsApp your comments and questions right here on ACT and The Voice.
Kids Classic TV on ACT and The Voice.
You ding-dong! You're supposed to be watching for cases!
You have to learn to relax, Jimmy, right?
Certainly. I've often thought of Muppy here as about the cutest little fellow around.
The Fraggle is most assuredly the best of all possible creatures.
Yep. But remember, he who laughs last, laughs last, laughs last.
No harm will come to you here. My name is Michael, and you are in heaven.
Elaine, now come on, try it. Well, okay, if you say so. How is that, TC?
Saturday mornings just got a whole lot better on ACT and The Voice.
Welcome back. And before the break, we were looking at type 1 diabetes. This second segment, we're going to be looking at type 2.
Well, we're going to touch.
We have an interesting clip.
Yeah, we're just going to touch on type 2 diabetes because really the emphasis was on type 1 today. But just to say type 2 diabetes is a different animal. I call it a different animal, different disease to type 1. People ask, are they type 1? Are they type 2s? Well, there are blood testing, blood tests we can do. There's the C-peptide levels, GAD antibodies, islet cell antibodies. So, if I have a young patient or even an older patient who comes in with a lot of weight loss, they are excessively thirsty, passing lots of urine, and they're very slim, the red flag comes up, and I think, could this person be a type 1? I would do those blood tests. So there are ways of telling whether you're type 1 and type 2. But just to say about type 2, I personally think it's a much more fascinating illness than type 1 because you're dealing with something called the ominous octet. Just impressing you with that term, the ominous octet. You're dealing with the liver, the pancreas, the alpha, beta cells. You're dealing with the muscle. You're now dealing with the kidneys. You're even
8 different parts of the body.
you're even dealing with the brain.
Yeah.
We now know that the brain has a part to play in type 2 diabetes. So we won't get into all of that maybe another time. But
we did do that, did do a program on the ominous octet.
Ominous
Yeah,
octet.
before. Yeah.
Right. So we do have a slide on type 2 diabetes, and it's really a mixture of insulin deficiency. So the pancreas is producing some insulin and insulin resistance.
Okay.
So even the insulin that you're producing is not acting effectively enough. So we can go to that second clip on type 2 diabetes.
Type 2 diabetes is a metabolic disorder that causes sugar, in the form of glucose, to accumulate in the blood rather than being used as fuel by the cells in our body. When we eat, food is broken down by our digestive system into nutrient molecules that are then absorbed through our digestive tract for use by the body. Foods containing carbohydrates or various sugars are broken down into glucose. Glucose is an important source of fuel for many organs in our body. However, to be able to use the glucose for fuel, the glucose molecule must first enter into the cell. The pancreas produces a hormone called insulin, a chemical messenger essential for the entry of glucose into cells. As the blood glucose levels rise after a meal, insulin is released into the bloodstream and sets processes in motion to trigger the removal of glucose from the blood to enter into the cells. In type 2 diabetes, the cells become resistant to insulin and ignore its message to absorb glucose. This is known as insulin resistance. In addition, in type 2 diabetes, the pancreas is unable to produce the greater amounts of insulin needed to trigger these resistant cells to take in glucose from the bloodstream. The most notable symptom of diabetes is frequent urination and excessive thirst. Other symptoms include weakness, drowsiness, and blurred vision. These are caused by chemical imbalances in the blood related to high levels of blood glucose. About 1 in 4 people with type 2 diabetes are unaware that they have the disease. It is important to catch diabetes early. Over time, high blood glucose damages the blood vessels, which can damage the organs that these vessels supply, leading to a variety of health complications. Damage to the small or micro blood vessels can cause vision problems, including loss of sight, nerve damage, and kidney disease. Damage to larger or macro blood vessels can lead to cardiovascular complications such as heart disease, stroke, and poor blood circulation. Overweight and inactivity are major causes of diabetes. A family history of diabetes significantly increases your risk of developing the disease. Certain ethnic populations are also at increased risk of developing type 2 diabetes. Finally, some medications may increase your diabetes risk, specifically corticosteroids, thiazide diuretics, drugs used to treat certain mental illnesses, and some antiretrovirals used to treat HIV infection. In summary, type 2 diabetes is a metabolic disorder. It causes sugar, in the form of glucose, to accumulate in the blood rather than being used as fuel for the cells in our body. If not diagnosed and treated in a timely manner, type 2 diabetes can lead to many health complications.
Again, another very graphic description of the role of insulin and how it works in the body with type 2 diabetes.
Yeah.
So maybe we can make some comparisons between the type 1 and the type 2.
Well, there's a slide here that, again, shows how does insulin work. Slide 10.
Yeah.
We can bring up slide 10. So you can see that basically 3 different organs in the body where insulin is working. The top is the adipose tissue, that's fat. So what happens is that with insulin therapy, sugar goes into the fat tissue where it should be, and it decreases what we call lipolysis. Lipolysis is fatty acid production, and I'll explain that. Insulin also helps sugar to go into the muscle, where you need sugar as a metabolite to help the muscle to work efficiently. And then the liver is the next big organ where the insulin is working. And what insulin does, it helps the body to build up glucose stores in terms of glycogen, and it decreases glucose breakdown. So we can come off that slide. Now, why is that important? So a lot of patients complain, Doc, I'm putting on weight when I go on insulin. Why is that? Actually, if you're putting on weight, it means the insulin is working. Why? Because before we put you on insulin, if your diabetes is poorly controlled, you're literally eating and you're leaking out or urinating out sugar. So you're losing calories. When we give you insulin, the body begins to utilize those calories more effectively. So that's when you need to start exercising, etc., to keep. But the insulin is doing something very important, because the longer the sugar stays in the blood, that's when you do damage to your organs. The other thing about the liver is that a lot of people complain they go to bed with a blood sugar of 100, 110, and they get up with a blood sugar of 180, 190. That's called a dawn phenomena.
Yes.
And basically what the body is doing, and it happens in all of us, diabetics or not, the body's preparing you for the activities of the day. So it's storing, and then it's releasing sugar in the early hours of the morning, and that's why there's an arousal state in the early hours of the morning, because you have cortisol levels, you have adrenaline levels, and then you have sugar being released. The problem with diabetics, there's not enough insulin to control that sugar coming out of the liver, and therefore you end up with a higher blood sugar than you went to bed with. And there are ways of treating that.
And so what do you do about the weight gain that's associated with insulin?
Well, in type 2 diabetes, we now have some new drugs in the market. There are the DPP-4 inhibitors, there's the SGLT2 inhibitors. There are drugs that people would have seen advertised, like Invokana, Forxiga, Jardiance. And I am now combining those drugs with insulin in type 2 diabetics, and we are seeing some weight loss, because those drugs encourage glucose, sugar excretion in the urine. So you're losing calories, and it actually protects the kidneys and the heart. But I don't want to go too much into that today.
I just wanted to remind the viewers that we're not live this evening. So if you do have queries, you can call, but the number is going to be 482-4269, and we will try and get back to you after the program with our responses to the questions.
Yes. So we wanted to really dig into insulin itself, and this is could be a complex topic, so we want to make it as easy as possible. And I just wanted to go into the different types of insulin, because we have already showed how insulin works.
Yes.
And again, Linda, I just want to remind our viewers, and I know I said it in the first segment, insulin is not bad. I want to repeat that. If you go to the fake doctors and they tell you that take my herbs because you don't need insulin, and you're type 1, we said you can end up dying. Even in type 2s, you can end up with serious illnesses. So insulin is essential for survival. And in fact, when Banting and Best discovered insulin in 1920, they were given a Nobel Prize. And it changed the face of how we understood diabetes and how we treat diabetes. So there's slide 19, Linda, which is a little bit of a complex slide, but I'm going to try and show it. This is called the action profiles of insulin. So on the horizontal axis, this is you see the time of action of insulin. So on the left-hand side, you see the rapid insulins like Lispro, aspartate, some people call it Apidra, Novorapid. They work within 30 minutes.
That's the first pink one.
Yes.
Yeah?
And then you have
purple one.
Right.
Yeah.
Those are very rapid analogs. Then you have...
So within 4 hours, you can get it going. It's finished.
It's finished.
Yes.
Then you have the regular insulins, rapid insulins, which we haven't seen that.
That's the blue one.
Blue one. They take about an hour or two to start acting, and they stay in the body for 6 to 8 hours.
Okay. And
then the green line is the N insulin, which is part of 70-30. That takes about 6 to 8 hours to start working, and they stay in the body for up to 16 hours.
And then...
Now, forget about ultra lente, but now we have the newer insulins like Detamir and Glargine or Lantus, and you notice they have a flat profile.
Yeah.
And I'll explain what that means when we come off the slide.
That's about the plasma insulin levels.
Yes.
Yeah. Okay. So
we have been having this debate about types of insulins, and of course we know we are living in an economy that is stretched, and we have to make sensible decisions. For example, we had Lantus available on the government system up to about 2 or 3 years ago, and the powers that be decided that Lantus was too expensive and that NPH or 70-30 insulin was good as Lantus. I want to say that whoever made that decision just simply does not understand how insulin works and how effective the long-acting insulins, the basal insulins, are. And I know the people who made that decision, and there are some people who felt that personally that I was too much in favor of Lantus. But let me just say, Linda, bringing the measure we use is the HbA1c.
Yeah.
When you tell someone they have an HbA1c of 7%, which is your target, it is true to say that the older insulins might be as effective at bringing the blood sugars down to that level. What we miss, though, and last week we were being trained on insulin pumps, what is showed is that the older insulins have much more peaks and troughs. So people have much more frequent high levels and hypos. They may end up with the same A1C, but diabetes has advanced. So now we know that it's not just an A1C we are wanting to try and prevent the variability of the glucose.
Because, I mean, with any system, if things are going up and down all the time, it's stressing your system.
Absolutely, absolutely. So, we understand why the decisions were made because of economic reasons. But what I want to say very clearly, we need to be honest with our patients. When we make a decision about a generic drug, for example, the Ministry of Health has decided to bring in a lot of generics. We have to be cautious and say that this is being made on the basis of an economic argument rather than the quality of the drugs. Because I want to suggest that there's very little quality testing of drugs in Trinidad. And I'm saying that very confidently. People may want to challenge me on that, but we don't have the facilities. So generics are coming in from India, from various areas in the world, and we are replacing it with the originals, and we are telling patients they are just as good. That is not true.
Yeah. Not good health care.
And also, with insulins, although you are achieving a similar blood sugar level in the end, what you have to weigh up is, are you taking those people through a lot of ups and downs and therefore putting them at increased risk? I
remember you mentioning the ominous octets.
Yes.
Can you re-identify what those are? So the organs that will be affected and be going up and down in terms of function.
Well, that's in type 2 diabetes, bear in mind.
Yeah.
In type 1 diabetes, you're mainly dealing with the beta cell, although, we are talking about a type 1.5 diabetes.
Yeah.
I don't want to get too complex, but we are seeing some type 1s with insulin resistance. which you wouldn't expect.
That's unusual, yeah.
Yeah. So we are seeing a kind of diabetes is not as straightforward as people think, that you have type 1, you have type 2, you have gestational diabetes, which is diabetes in pregnancy, but we even have a kind of type 1.5 where we know people are type 1, but and I have a patient like this right now. He's almost 20 years old now, and he's needing a lot of insulin, and it's clear that he's insulin resistant. So therefore, in the years ahead, he may do well with added medication to his insulin to try and bring down his insulin requirements.
Okay, right. I'm not sure how long we have before the next break, but what about the targets?
Okay, so we had some slides on this, but again, I don't want to make it too complex. What I would say is that in young kids, it is very difficult to get them as well controlled as adults. Mm-hmm. So while we say that in adults, we are trying to get their A1Cs, that's the 3-month average less than 7. In kids less than 5 years old, if you can get their A1C around 8 to 8.5, you're probably going to be happy with that. As they get to their teenage years, and remember they're going through a growth spurt. I'm talking about type 1 diabetics now, and compliance is a big issue. So getting people to take, youngsters to take insulin. Remember, they're having to take injections. You remember that you are having to get them to eat the right things. So an A1C of around 7.5 might be okay. When they get to 20, then we would say, okay, let's really try to get the A1C down to 7 or 6.5. So,
and then children are a lot more active as well, aren't they? So they
absolutely.
Hopefully.
Yes. Well,
in this digital age, maybe not.
A lot of children are sitting a lot. Yeah. Yes. So
type 1 diabetics need to be exercising.
Well, type 1 absolutely. I mean, and I would tell parents that in this very academic environment we live in, where from 9 and 10 they're doing SEA, extra lessons, etc., people begin to put on weight. And once kids begin to put on weight from a young age, it is very difficult for them to lose it as they get older. So even if they are type 1s, they should be exercising and should be fairly active.
Good.
So I wanted to go on to, because I know we have to go to a break soon. I think we have about 2 more minutes to the break. So I just want to introduce the different ways of giving insulin.
Right. Okay.
So slide 20. So slide 20, hopefully that will be up on the screen. It shows how can insulin be delivered. So the traditional way is drawing up insulin from a vial. And unfortunately, I don't have the vial and syringes.
I think everybody knows what a vial and a syringe looks like.
Okay. Then you have the insulin pens, which I'll show you. And then you have the insulin pumps. And I just want to show, actually, the next slide, which is slide 21. Slide 21. Slide 21. Yes.
That's it.
So that's the old-fashioned way of giving insulin. So you see the bottle, you see the syringe. Basically, the bottle will have about 1,000 units of insulin, and if it's a mixed insulin, you have to shake the bottle to get the suspension equally distributed. You change. You turn the bottle. You turn the bottle upside down. You pull up the syringe with air. You inject the air into the bottle, and then you pull up the syringe to 5 units, 10 units, 20 units, etc. So that's the insulin syringes. So we can just come off that.
Okay.
Now,
so there are 3 methods of delivering insulin. That was one.
Syringe, and when we come back from the break, we'll show the insulin pens and the insulin pumps. What I would say is that, unfortunately, on the government service, we still only have the option of syringes and vials.
Okay.
Now, I say unfortunately because it's really, while it can be effective, for a lot of younger people who are working, etc., we need to move on from that. But I know we have to go to a break, so when we come back, we'll talk about.
Okay, so when we return, we're looking at insulin therapy today. We look at the other two forms of delivering insulin to your body. Don't go away.
Kids Classic TV on ACTN The Voice.
You ding-dong! You're supposed to be watching for cases!
You have to learn to relax, Jimmy, lad.
I'm certainly. I've often thought of Muppy here as about the cutest little fellow around.
Fraggle is most assuredly the best of all possible creatures.
Yep. But remember, he who laughs last, laughs last, laughs last.
No harm will come to you here. My name is Michael, and you are in heaven.
Elaine, now come on, try it. Well, okay, if you say so. How was that, TC?
Saturday mornings just got a whole lot better on ACTN The Voice.
Welcome back to Your Health, Your Choice. We've been looking at insulin therapy, and before the break, we looked at the first form of insulin delivery, which was syringes and vials.
Yes.
Obviously, we have with us Dr. Claude Khan, but this evening, of course, there is no live broadcast, so you won't be able to call in. However, you can call on 482-4269, and we will try and get back to you with your answers to any questions that you do have. So let's look at the second form of delivery.
Right. So we talked about the vials and syringes, but insulin delivery systems are rapidly developing. And I think it's unfortunate that we don't have these under government service. So this is an insulin pen. So it comes with a cover. You can keep it in your pocket. You don't have to keep it in the fridge for up to 30 days. You wouldn't leave it in the car exposed to the heat, but you can keep it in your pocket. And even if you're working outside, you can keep it with you. You just remove the cover, and the insulin is stored in this area, and they're up to about 300 units. And the needle, if you look at this needle, it's a very, in fact, tiny. On the camera,
was invisible.
Yes, it's a very, very tiny needle compared to the insulin syringe. Mm-hmm. And basically, all that you have to do is you dial up the insulin that you need. And you can dial in 2 units at a time, 16, 18, 20, whatever insulin that the doctor tells you. And then basically, it's an injection. It's an injection, and the best place is to give it in the tummy area. Mm-hmm. And it's a simple action where you just go straight in. Now, it can't go further in than the guard here. And the tummy is the best area. And you go straight in, and you just press the top, and the insulin goes in. And as you press, the insulin comes out. Right, you're seeing the insulin. Yeah. And so that it goes right up. All right. And then it goes back to 0. And you will know that you're getting the insulin because this little black bung comes down. So you know you have 200 units left, etc. Yeah. Now, this is a much more accurate way, apart from convenience, this is a much more accurate way of giving insulin because you're not having to estimate. Because remember, a lot of diabetics are visually impaired. Yeah. So they're trying to pull up this. Yeah. And I have looked at these syringes, Linda, and they're not easy to estimate if you're on 22 units, 24 units, etc. So the syringes can be challenging for elderly people, whereas this is a much easier device. It's much more accurate in giving insulin, and also you can store it. Yeah, much easier. Now,
I noticed that you have it's like, are these are color coded for a reason?
No. The pens are color coded. Right. So this is a gray pen. This is a long-acting insulin called Lantus. Mm-hmm. And there are different types of basal insulins, long-acting insulins. There's Levemir, And then this pen, which is the blue pen, is what is called a PEDRA. It's the rapid-acting insulin. It's a similar way of giving the insulin. You dial up again, and you press. Now, and this insulin is given just before meals. So we have these available in Trinidad. It's easily available.
So
but
would you need both? Or
right.
Do you...
So in type 1 diabetes, yes, you need both. Why? Because the way your body works is that you're producing a constant amount of insulin, and when you eat, your body produces a surge of rapid insulin to cover the meal. In type 1 diabetes, you lose both the long-acting insulin and the surge. In type 2 diabetes, sometimes you can get away with just one injection a day of the basal insulin together with tablets.
Okay.
And that, you can treat patients effectively with that for years. Sometimes they may need a second injection, but a lot of type 1s will need the long-acting insulin once a day, and then the rapid, which is the blue pen, or whichever rapid insulin you're using, up to 3 times a day.
Okay, so I know what is uppermost in most people's minds is cost.
Right. So an insulin pen like this is about it's about between $180 to $200. It has,
how long will it
right.
last?
Okay. So it has 300 units. So let's just say you're using 20 units a day. It will last you 15 days. So for the month, you're talking about 2 pens. But the cost, unlike tablets, which is a fixed dose, and I always remind patients of this, there's no upper limit to insulin or lower limit. In other words, everybody's different. So if you come into me and you're 300 pounds, 10 units of insulin will not touch you. You probably will need 80, 90, even 100 units of insulin.
And if you lose the weight, what happens?
Excellent question, Linda. That's where in type 2 diabetics now, gastric bypass surgery is becoming very popular, because if you lose 20% of your body weight, now if you're 300 pounds, 20% is about 60 pounds.
Yeah.
That's not easy. But if you can lose about 20% of your body weight, a lot of people can reverse. I don't use the word cure.
Yeah.
And again, for all the fake pretend doctors out there and herbalists who are telling people they can cure their diabetes with Omega XL, it's a lie. You are being deceptive. You cannot cure diabetes. You can reverse diabetes. But talking about curing diabetes, type 1 is where we get into stem cell therapy. And very rapidly, let me just say, I know there's a company in Trinidad that is saying that they're offering stem cell therapy. Up to this week, I heard on the international medical news that stem cell therapy is now being introduced in research areas for Parkinson's. So I find it hard to believe that there are companies in Trinidad being able to do stem cell therapy for type 1 diabetes, type 2 diabetes, Parkinson's. This is in Japan. It's been pioneered.
I know that stem cell therapy has been effective with MS, though.
Yes.
I know personally of a case where it has been successful. Not in Trinidad.
Stem cell therapy,
yes.
Or you're talking about brain cell stimulation?
No. Stem cell therapy for somebody with MS in the UK.
Oh, MS, yes, definitely. But I'm talking now about Parkinson's. But what I'm trying to say is that it's such a new therapy that we have to be very cautious when we hear people saying that they're offering stem cell therapy for diabetes. But weight loss in type 2 diabetes, definitely you can decrease the amount of insulin you need.
So our cameraman has just been warning us that we have 10 minutes left. The third, maybe we should go on to the third form of delivery of insulin.
So we have been waiting for insulin pumps for quite a while in diabetes, for treating type 1 and type 2 diabetes. And we were planning to bring in these pumps some years ago, but because of the cost and foreign exchange. But now there's a company that is partnering with a company called Medtronic in the US. And we were, a group of doctors were on a training course just this week or last week on the insulin pumps. So this is an insulin pump. And what you have at the top here is where the insulin reservoir goes in. And then you have, it looks complex, but it's easily manipulated where you set the dial. So this pump fits onto your belt or your waist, and there's a cannula, a needle a small needle that goes under the skin, and it stays there for up to 3 to 4 days. So you're not injecting 5 and 6 times or 4 and 5 times a day.
Right.
And what you do, the pump is filled with only rapid insulin. And there's a continuous infusion of insulin, rapid insulin. And then when you're about to eat, you calculate your carbs. And this is an amazing...
Calculate your carbs before you eat.
Right. So we teach patients how to do carbohydrate counting.
Right.
How much more time we have? About 9 minutes. We teach patients how to do carbohydrate counting. But even if they can't do carbohydrate counting, they can still use pumps. And you can enter the carbs.
Right.
You do a blood sugar reading just before, and there's what is called...
So the pump does the blood sugar reading?
No, you have to do your... Well, right. You can have a continuous glucose monitoring device, which is the next... I don't want to talk about that today.
Right.
But you can do a blood sugar reading. You enter the blood sugar reading, and there's a bolus wizard. Wizard sounds magical. A bolus calculator. The pump calculates for you how much insulin to send into the body.
Right.
The pump actually does the calculation. This is one of the latest insulin pumps. I think it's a 6.2 something model. So the pump tells you need to bolus in 4 units or 5 units. You then just dial up the units, and it goes in automatically.
Where do you do the dialing?
Well, it's these little devices
so it's just
here.
Like, it's like one of those video game things.
Right. It's
or remote control.
Remote control.
Yeah.
Okay. So this is the latest device that's now on the market. I could tell you what the price is in a few minutes if people really want to know.
Yeah.
But it's not cheap. It's not going to be cheap to start with, and we're hoping that the insurance companies will cover it. Now, why is this so important, Linda? Not everybody will be suitable for a pump.
Who is not suitable?
Who's not suitable? Well, a lot of type 2s will not be suitable for pump therapy, more type 1s, but there are a lot of type 2s who will do well. But you have to be compliant. You have to be willing to be trained, and you have to be willing to do regular blood sugar readings. We only have about 5 more minutes.
I realize this.
Right. So if you are not willing to do the hard work, we often say there's no gain without pain.
Yep.
The insulin pumps have been shown to improve blood sugar levels, etc. It is quite expensive to start with. Insulin pump might cost about 30,000 to 40,000 TT. So
that is a lot of money.
It's a lot of money. I agree, but one pump can last you for years. But
and then you're looking at the long-term effects as well.
The long-term effects, but of course you also have to pay for the monthly supply of insulin. The pump, well, it depends on how much insulin you're using. But the pump itself is around 30 to 40,000. Now, some insurance companies, hopefully, we're trying to get insurance companies to understand that they need to cover these devices. Because I'll tell you, if you're in America, most of our type 1s would be on an insulin pump, and it's covered by insurance policies over there. So there's no reason. All the big companies, Guardian Life, Maritime, Sagicor, Algico, all you insurance companies, you get your act together, and you need to understand that insulin pumps is the new it's a front line of treating especially type 1 diabetics.
Well, it does, in comparison with the kind of operations that you may need to do if you without the insulin.
Yes.
In the long term, it does make sense to invest in one of those.
Yes. So what I would say is that, you know, we are excited about this, but let me just say, maybe only less than 5% of the diabetics in Trinidad would be suitable for an insulin pump. So it's going to be a small section of the population.
But at least they know it exists.
But at last, after insulin pumps have been around for 30 years.
But now available in Trinidad.
But finally, now it's been available in Barbados. Dr. Carly Goddard, who has we know very well, he's had an insulin pump center. One of the things I would just want to say, I don't think any one doctor in Trinidad can handle this on his own. So I am suggesting to some of my colleagues that we set up a pump center where patients can come in, they're diabetes educators, and they can be trained, and patients can have the resources. So, you know, we are sharing the expertise. We have no need to compete against each other where this is concerned.
No. Okay. So we have 3 more minutes. That's where you're allowed to put on your pastor's cap.
Oh, am I allowed to put on my pastor's?
Spiritual to share with us?
Well, you know, we have been talking about the giants, Goliaths in our life. I've been reading a book called Goliaths Shall Fall. And, you know, we face the giants of fear. And especially in Trinidad right now, there's so much fear of kidnappings and murders. And literally people are wanting to flee the country.
It seems to happen every 20 years. We had the Black Power movement in the 70s, the coup in the 90s, and it looks like we're overdue for one.
Don't say that, Linda. But if you are facing the giant of fear, the giant of rejection, the giant of despair, the giant of low self-esteem, I want to suggest to you that if you have a faith in God, there's a scripture verse, and we're coming from a Christian tradition. God has not given you a spirit of fear, but of power and of love and of a sound mind. Can I say the Goliaths in your life start in your mind? And if you can literally immerse yourself in the Word of God, immerse yourself in a faith community, immerse yourself in doing things. You know, we had a family fair recently where people were so excited. New people in our church led the charge, and they were so excited about helping the community. A lot of those giants will fall in your life. So I want to say to you, if you need advice, we have professional Christian counselors at our practice. We have people who can pray for you. You can ring in at 482-4269, 482-4269, and we can set up appointments, etc. for you if you need that. But Goliaths in your life shall fall. Linda?
And globally as well.
Well, yes. We have global giants.
We have the 5 global giants that we are trying to address in our peace plan at Anaposis Chapel. The spiritual emptiness, self-serving leadership, poverty, disease, and illiteracy. And through the power of ordinary people in local faith communities, we can address those giants practically. So join us again for another edition of Your Health, Your Choice in a fortnight's time.
Can I just say, in 2 or 3 weeks' time, I'm going to have Dr. Yadish Singh.
Yes.
And he's a laparoscopic surgeon, and he's the one who did my surgery, for those of you who know what my situation was. And I'm excited to have him on the program in a few weeks' time.
Great. And that gives me a break for a month. Thank you very much, and good evening. We'll see you in a fortnight's time with Dr. Yadish Singh and Dr. Claude Khan.